It is about bhagna chikitsa. अथा तो bhagnaनां चिकित्सां व्याख्यास्यामः यथोवाक्यं भगवान् धन्वन्तरिः। अल्पाशिनो अनात्मतः जन्तोः वातात्मकस्य उपद्रवैव दुष्टस्य भग्नं कृच्छेदसिद्ध्यति। लवणं कटुकं क्षारं मूलं मैथुनमातपं व्यायामं च न सेवेत भग्नो वृक्षान्नमेव च। शालिः मांसरसः क्षीरं सर्पिर्यूषः सतीनजः ब्रह्मणं च अन्नपानं स्यात् तेन भग्नाय जानत। Now, the bhagna nidana we have already studied, and then the different types of the causes of the fractures and dislocations we have studied that. So now about the management. In the management, the first priority is given for the diet and the exercise, which would be suitable for that. Persons who do not have or who are poorly nourished, Alpashnaha is poorly nourished. Anatmamraha is those who do not have a willpower, because management of the fractures is a prolonged treatment and it involves a active involvement of the patient. The cooperation of the patient is absolutely essential, and hence those who do not cooperate or who do not have the willpower to tolerate the pain, they would be difficult for the treatment. Our orthogen prakriti patients, our patients who have complications, they are poor prognosis, having poor prognosis, difficult to manage the conditions of that sort. And the person has to avoid the food like lavanam, katukam, ksharam. The pungent food, irritant food substances have to be avoided, and he should avoid the active movement of the body like regular sexual exercise or any other regular exercise, or moving it in the sunlight also are to be avoided, because he needs physical rest and a nourishing diet. And the nourishing diet suggested by Sushruta Shalihi, Mamsarasaha, the Mamsarasa, soup of the flesh, or Shali Anna, Shira and Sarpihi, Ghrita, Yusha Satinaja. Satinaja Yusha. Now Satina Dhanya is one of the dhanya variety of the argar seed. It's also called as latirus. The latirus is the other name for satina dhanya, which is often mixed with adulterated with the argar seed, these acid. Now about this latirus acid. The laterals is satina is considered as an apaksha in Charaka Samhita, and even in Sushruta among the apaksha dravyas satina is included. But in case of a fracture management, this is considered as one of the paksha. That's a very interesting. Laterous seeds are known to produce mobilization of the calcium and produce osteoporosis. And there is one specific disease called latirism. Latirism, those people who consume latirus seeds in excess, particularly in some areas of the country, this is common. In Karnataka, in the Handigod area, in the Shivamogga district area, you have these incidents of such diseases more common. That's also called as Handigod syndrome, which is related to the consumption of the lateral seeds as well as the fluorides in the water. Handigod syndrome is a disease where there will be osteoporosis and a deviation of the bones. Now, that's a very interesting issue. The lateral seeds are known to mobilize the calcium from the bone, and during the healing of fracture, that fast mobilization of the calcium is one of the factors which can help in faster recovery. Healing process of the calcium, the factors needs a faster deposition of the calcium, and hence during the management of the fracture, this is considered as a pathya, whereas satina dhanya otherwise is a apathya dravya. That's a very interesting issue, and identification of such a complicated clinical observation and utilizing this as a utility, clinical utility is the speciality of Sushruta. Then Brahmanam cha Annapanam Syate, any other Brahmana Annapana has to be given. In the present day situation, there are some standard diet suggestions for the bone fracture as such, and this is one of that usual plan, like bone fracture diet is seen, like where you will have a suggestion about 600 milligram calcium. Calcium is given in excess. Now, calcium given in excess along with the others, of course. Others I don't have much of objection, like sodium and carbohydrates, potassium, and so on. See, calcium directly given might not help in really healing of the bones. Only in those persons who have a calcium deficiency it may help. But otherwise, it's what you need is a calcium mobilization, a mechanism by which the calcium metabolism can be enhanced. And to a certain extent, this is facilitated by the phosphate containing substances than the calcium. Directly calcium given is not easily deposited in the bone as such, rather it may get deposited in the other areas of the body. But customarily, at present, if you go to any orthopedician or any situation, even the standard protocol guideline given universally is recommending calcium to be given in case of a fracture management, but real utility is questionable. Rather, that satina dhanya, something of that sort which mobilizes the calcium and increases the calcium in the serum, but reduces the calcium in the bone temporarily, during the course of the healing, can help in the healing of the fracture. That's a very interesting observation. Anyway, that's about one of the. That's diet is one factor. Of course, we come across the diet again next part. Madhuka Udumbara Ashwata Palasha Kakubat Prajaha Vamsha Sarjavatananta Kusharkam Upasam. Kusha is the splints used for the fracture management. See, in the fracture management, the fracture has to be immobilized, and for the immobilization, you need the splints, and the splints in Sushura's period were prepared out of barks of the tree. And barks of the tree like Madhuka, Udumbara, Ashwatha, Palasha, Arjuna, or Vamsha, bamboo, or Sarja, what are the barks of these trees were used. Now, if you go into the history of fracture management throughout the globe, there is an evolution of these materials used for the fracture management. Historically, you get these kinds of history in 3000 BC, the leathers of animals and boxes like structures were used for immobilization. Then gradually there were some the linen but cloths glued together, stuck together. They were used for fracture management up to in the BC and the AD period, right? If you go into the history throughout, and then in the Roman plaster of Paris came into use by around 1768. And from that time onwards, the most popular material used for the immobilization is the plaster of Paris. Now, of course, you have some synthetic materials, and even the fiberglass are used for the immobilization. So, the basic qualities of a substance which can be used. Now, this is about the historical picture. Ambrose Paré, who is considered to be the father of the modern surgery, he used to have the same similar barks of the tree, tie it together. The image is a image drawn by some artist of that period, maybe somewhere, and if it is available, it's considered to be the image of Ambrose Paré's period. That's 19th century, earliest 19th centuries. Now, anyway, where the fractures were managed with the splints which would be tied around the area. So this picture is almost a similar picture to that of what Sushruta had maybe possibly had prepared the splints as well. Now the barks of the tree, when they are used for this fracture management, they may not fit well to the parts of the body, and to make them suitable to the parts of the body, to make them exactly producing a uniform compression over the body, before applying these barks of the tree, Sushruta had suggested to apply a leper, a flexible pasty substance, and at the base of the substance prepared was Manjista, Madhuka, and Shalipista with the Shabda. Shalipista, the flour of the rice, with the Manjista, Madhuka, and Rattajandana, and Ghृता. Now, this would be something like the plaster of Paris. When it is hardened, it produces sufficient resistance, and only the difference between the plaster of Paris and this would be plaster of Paris would dry up quite early, and it gives more strength. Plaster of Paris is stronger than this. Whereas this will not be as strong as the plaster of Paris. It may take a very longer time for dry up. So till it gets dried up, the patient had to be immobilized, cannot move even a little. So the idea is you have to apply the lepa around the limb, then over the lepa, the barks of the tree have to be tied and they have to be fixed permanently. And once they have put it firmly tied, the tying should not be continuous. It has to be like immobilization is not continuous. The barks of the tree had to be changed at regular intervals. And it depends upon the seasonal practice, because the barks of the tree would be drying up quite early in hot season. Sushruta would suggest like you have to change them once in 3 days, or in cold season where it may not dry up so fast. The frequency of changing these external splint could be once in a week. That's what Sushruta has mentioned as saptaha saptaha saumeshu ritushu bandhanam sadharaneshu kartavyam panchame panchame ahani agdeyeshu trayha kuriyat bhagnam doshavashena va. Now, once in 7 days in case of cold season, and once in 3 days in case of hot season. In a moderate season, once in 5 days, that has to be changed. Now, changing the band-aid or changing the splint at regular intervals has both advantages and disadvantages. The disadvantage would be like, because you change every time, there is a possibility of mobilization of the bone, and that mobilization of the bone may not help in healing. It may just interrupt in the process of the healing. Whereas the present trend of POP splint, like rather current trend in the sense, a few years back, this was a very popular technique, like a POP splint was used. POP splint is applied over the area, and the POP splint would also have some drawbacks, where you do not have to change once in a week or once in such a, like the trend initially was to put the POP splint, and till the total union has occurred, the same splint will be used. When you use these kind of splints, the disadvantage will be there could be two possibilities of edema. Either there could be edema before you immobilize, and once you have immobilized, the edema gets reduced. And if the edema gets reduced after your POP splint, there would be a gap, and that gap would facilitate the mobilization of the bone, and the healing would be delayed. Or the other way, there could be a possibility the other way, like initially there might not be edema, but after you have put the splint, there could be some edema formed, and that edema would produce more compression, and that extra, because the POP splint is not flexible, there would be more compression, and that compression would be again producing pressure over the soft tissues, and necrosis can occur. And if there is a compound fracture and there is a wound with the POP splint, wound care is quite difficult. You will have to keep a window there to take care of the wound, and keeping a window over the POP splint can reduce the strength of the total splint asset. Maintenance of the hygiene also is an issue with the POP splint, which is kept for a long duration, for 3 weeks or 1 month or so on. When you use a POP splint, you have to immobilize, as a general rule, at least 2 joints to immobilize the bone. At least 2 joints, one joint proximal and one joint distal to the fractured area has to be immobilized, and this immobilization, prolonged immobilization, can result in a stiffness or osteoporosis, or at times it can be a cause for the compartment syndrome. Compartment syndrome is due to the compression of the tissues around the area. There could be a possibility of compression of the nerves, and hence there could be continuous pain. One of the major, very troublesome complication of the fracture union. Now, these complications can be minimized by a habit of changing the splint at regular intervals, maybe once in a week or so on. But at the same time, changing the splint also helps in a better healing or better functionality, because there will be a better circulation of the blood, and every time you change the splint, there will be some specific modulation of the shape of the organ, shape of the bone, so that the functionality could be better. Of course, if you are not careful during the mobilization, there could be a breakup of the tissue there, and the healing can be delayed. Now, the latest trend in the management of orthopedics would be, instead of a POP splint, there is always a preference for a dynamic splinting. Dynamic splinting is where you use either a simple crepe bandage or some elastic substances which are used, or now you have many varieties of materials which are available, like velcro tapes as such, or bandage braces as such, or some springs and so on. Lots of modifications are there, and lots of such materials. Dynamic splinting are available now, and in many of the fracture conditions, this has become a standard protocol where there is a partial immobilization, at the same time there is some amount of mobility left over. Now this kind of a concept of some mobility in between the immobilization, a partial immobilization with some amount of the mobility, is the theme of what Sushruta has suggested by changing the bandage regularly. Now in the present day situation, that theme is now, and that idea has gained the popularity, or the importance of that is now known, and hence the latest trend in the management of the fracture is try to avoid POP as much as possible. Of course, in certain conditions, it's still not possible to use these kinds of the dynamic splinting conditions, but as far as possible, the first priority would be always to use dynamic splinting, and devices which can have this kind of a help or this kind of benefit are now coming up very rapidly. In the market, you will find lots of such devices which enhance the scope of such materials being used as such. Anyway, that's about one important point which has a very significance from the current point of view. Then when you, in Sushruta's period with the bandaging was not done by a POP splint, instead it would be tied, as you have shown in the diagram, the earlier Ambrose Paris diagram. Similarly, there would be some tying with some rope or maybe the other materials like creepers or so on. And the tying should be of a moderate grip. तत्र अतिशिथिलं बद्धे सन्धिस्थैर्यं न जायते गाढेनापि त्वगादीनां शोको रूपाकैव च तस्मात् साधारणं बद्धं बध्ने शंसन्ति तद्विधः. In the case of Ranabandha, in the chapter of Ranabandha, we have discussed about that different modalities of the pressure which could be applied over the area, depending upon either the dosha involved or depending upon the location. In case of Ranabandha, either there is a Shithila Bandha which is preferred, or a Gada Bandha is preferred, or Samabandha is preferred. But whereas in fractures or bhagna, you are not supposed to use Shithila or Gada Bandha, it should be always a Samabandha, because Ati Shithilam Bandha, if it is a Shithila Bandha, there may not be a proper mobilization. If it is a Gada Bandha, it can produce edema of the soft tissues and even the septic complications, and hence Sadharana Bandha is preferred. Then once this is done, like the plaster of the pista is applied, Shalipista is applied, and then the splint is placed in between to facilitate the healing. Sushruta also suggests about the kashaya, negrodhadi kashayam sushitam parishetane, Panchamuli Pakvam to Kshiram Priyat Savedane, Sukostam Hotarim Matakazairam Vijanaka, Vitya Kalam Doshanta Doshana Ushata Samidan Parishekam Pradeham Chabidat Shita Miavaja. Now, to facilitate the healing and to reduce the pain, Sushruta has suggested pouring some liquids, either it could be Negrovadi Kashaya or any other Shitavirya Panchamula Kashaya or any other Shitavirya Dravya which can be used depending upon the season and the dosha. And this pouring would be helping in reducing the pain or even reducing or facilitating the healing of the bones, fractures. Right? There is another specific yoga called as Chakrataila. Chakrataila is a oil which is directly extracted from the mill, and as it is flown from the mill, it will be warm, and that warm taila directly from the mill, which doesn't have any fat decomposition, or a fresh oil, rather maximum fresh oil is also applied as one of the means. Or Chakratayala also, there is about two definitions of the Chakratayala. One Chakratayala is directly from the mill. The other approach of Chakratayala, or another definition of the Chakratayala is in those days the oil would be extracted by wooden mills, and once that wood is worn out, wooden mill are worn out, which we call as gada. Now, they could be broken down, that wood piece would be broken down and kept in a water, boiled in a water. That oil which was absorbed by that wooden mill would be collected, which would be floating over the water, and that would be collected, and that also is Chakratayala. Now, this is one of the concepts of making a micromolecules, the sort of nanoparticle, not exactly nanoparticle, making a micromolecule situation. Now, in the current pharmacology, to facilitate the drug absorption, there is a process of the similar issue where some porcelain sponge is used and the materials are passing through that, and that makes the size of the molecules smaller or particles smaller, microfine, and that microfine molecules would be better absorbed. Now, that kind of an unique idea of advancement of the or facilitating the absorption of a substance is the idea of Chakratayala. So Chakratayala could be prepared that way too. Practically, to do this kind of a protocol now would be quite difficult, because virtually you do not have that wooden mills now, and all the mills are of metallic type now, and hence you may not be able to get it. But theoretically, if you have grasped that theme of this Chakratayala, it gives an extraordinary skill of Sushruta to extraordinary skill of our ancient scientists to facilitate the absorption of the substances. Then another of the pathya, or the food substance, nourishment to the fracture management is Gristikshīram sasatpishkam madhuraushadsadidam shītalam lakshayayuktam pratar bhagna pibennaraha. Gristi is, according to Dhallana, is a prasama prasuta cow which has delivered for the first time. Or the another definition of Gristi is a sadhya prasuta gau also. Immediately after delivery, that also is called as Gristi. So Gristi word has two meanings. According to Dhallana, it's prasama prasuta. Prasama prasuta is the first delivery. Now, the milk of the cows, bovine milk, the colostrum, that first milk, and the natural, mature milk, the milk which occurs later, the difference of the qualities is now studied, well studied, and you get the data about that difference. And there is a huge difference, the difference in contents of vitamins, minerals, and the globulins, immunoglobulins. Particularly immunoglobulins, there is a huge variation between the mature milk and the colostrum, or the first milk, the Satyaprasuta. In case of the Satyaprasuta cow, the colostrum of the animals, particularly cow or any other animals, bovine colostrum, the data is available, and this shows a huge difference, and particularly nourishing value would be quite different. And Sushruta had made use of that also for the facilitation of the healing, which gives an extraordinary source of calories and the nourishment, nutrients, which will facilitate the healing. And again, it is the same milk is again re-impregnated, or rather strengthened further by adding ghee and madhuraushadhas. So, and Laksha is one of the Agrayaushadhi Parsandhana, facilitating the healing as such. And this is one of the suggested food for the fracture management. So, fracture management, the diet suggested by Sushruta is having all that high standard scientific background. That's the important issue. Then, Savarnasya bhagnasya vranam sarpen madhuttarehe pratisarya kashayestu shesham bhagnavadachareta. If there is a compound fracture, the first priority should be to manage the soft tissue injuries. The wound has to be managed, and for the management you have to use the kashaya, For Pratidharana, all the other concepts of the management of the Sadhyavarana are applicable, and after having that primary management of the wound, establishing the hemostasis, and if possible the wound has to be sutured or ensuring that the wound hygiene can be maintained, you have to put the splint and ensure the fracture has to be managed. Now, about the healing of the fracture healing is always a long process. It's not a short process. A wound healing may occur in 7 days or a week, whereas with the fracture, there is always a different phases as it, and that different phases would be initial phase. There will be a inflammatory phase which may occur or which may continue for about 1 to 2 weeks as it. Then after 2 weeks, there will be a real healing process, and that healing process would be continued for about 3 weeks. And by 3 weeks, there is always a possibility of a new bone formation. The new blood vessels are formed, that angiogenesis, new blood vessels are formed. In the initial phases, it is the inflammation of normal course, and the maximum of that new angiogenesis would occur by about 3 weeks or 4 weeks. 3 weeks is the average time period for this, and during this time there would be virtually a union of the bones. Union of the bones in the sense continuity of the bone is maintained, but the structured tissue is not normal. Then gradually there will be remodeling, that callus or that tissue which bridges the two ends of the bones are called as callus, which is a mass of calcium deposited over the blood clot earlier, and this maintains the mechanical continuity of the bone, but may not be the normal bone. But later on, gradually, it is replaced by the normal Haversian system of the bone, and it may take about a very long time, up to about 6 months, for a complete healing. So, you have two words in the fracture management, the healing and union. Now, the same, once there is a fracture, initially that gap of the fracture will be filled by a blood clot, and that blood clot will be gradually replaced by a fibrocartilaginous tissues. The fibrocartilaginous tissues come into the area and fill up the gap, and that once this has become stabilized, you will have a union of the bone. And the golden rule of the fracture is no union would occur before 3 weeks. The minimum period for the union of the bone is 3 weeks, and it can occur easily or it can occur better if the gap between the two bones is lesser, or the size of the blood clot which has to be replaced by the fibrocartilaginous is lesser, and there is no interruption in the process. Interruption in the process of the fibrocartilaginous occurs due to the movement. So that's the whole idea of the management of the fracture. In the management of the fracture, there are two important issues. One is the reduction and is the immobilization. The word reduction means the gap between the two bones has to be reduced, and this is done by re-establishing the anatomical entity after the fracture. So once there is a fracture and if there is a displacement of the bone, the displacement of the bone has to be corrected by re-establishing the continuity, trying to keep them together either by external force or, if there is a need, a surgical exploration. But reduction is to reduce the space between the two bones, and requirement of that blood clot to fill up the gap is reduced. And once it is reduced, then you have to keep it immobilized so that the process of the fibrocartilaginous development or the callus formation is not interrupted. And once it has been formed, which we call as callus, this is what we call as callus, which is really a spongy bone, and you do not have the Haversian system, then the immobilization may not be necessary, because by the time the bone would have the mechanical strength to bear the weight, and hence you can stop with the immobilization. But the healing process, it's a long time process which gradually is replaced by, where the callus is replaced by the normal bone as such, which takes about 6 months. This is the whole course of the healing of the fracture. From the management point of view, the current issue, the classification of the fractures would be, as we have discussed in the bhagna chapter there in the Nidana, it's Simple fractures are classified as spiral, oblique, or transverse, which will give you an idea about the shape of that gap formed and the size of the gap formed, and by that you can predict about the time taken for the healing, as well as time taken for the union, and as well as the other possible complications can occur. And if there is a multifragmentary fracture, if there is a non-compound simple fracture with multiple fractures, pieces of the bones are there, and then there would be always having a complication like if there is more than two fragments, they are called as multifragmentary fractures, which we have discussed there, like comminuted fractures, pitchita bhagna or churunida bhagna. The same thing, like the wedge fractures are either spiral, where there is a possible or partial injury, a low energy compression where the fracture line could be spiral, or it could be bending where the bone may be bent or crushed, but it's not discontinuity is that there is no periosteal discontinuity, that's called as bent fracture. And a complex multifragmentary fracture is always a segmental fracture where there will be a significant issue. That's how it's classified. For the now this classification is to predict about the complications which can occur. Now complications which can occur are multifragmentary fractures because there is a possibility of a bone piece which is avascular, and it may come in the way of the union of the bone. It makes more complications, and you have to take care of that small piece of the bone. With the wedge fractures, though there is no gap, there is always a abnormality of the shape of the bone, and you need to take care about that correction of the bone shape of the bone. A segmental fracture where there is a multifragmentary fracture and there is a complex issue, then because there is no contact between the ends of the bones, you need usually a surgical intervention or a open treatment is required. In a compound fracture again, because the whole issue becomes more complicated, and to plan the level of intervention in the management in the current orthopedics, compound fractures are again classified into different types. Type 1 is when the wound is smaller than 1 centimeter, clean and caused by a fracture fragment that pierces the skin. That's the wound is formed from the bone which is displacing the tissue, not from the external source. See, a compound fracture can occur due to two forms of the injury. There could be penetrating injury from the exterior which may reach up to the bone and produce a fracture. The other way, there could be an indirect trauma, bone may get displaced and a bone may penetrate through the soft tissues and produce an injury over the soft tissues. Now type 1 is that kind of a situation where the bone has become displaced and has penetrated through the skin, where the chances of contamination or the septic complications are lesser, and that's why, and if the size is less than 1 centimeter, then it's called as a, it's categorized as type 1. Type 2 is wound is longer than 1 centimeter, less contaminated, and again formed in a similar manner where the bone is projecting from within and produces the damage. But as the damage size is very increased, it is considered as a type 2. Then the type 3 is wound is longer than 1 centimeter with significant soft tissue disruption, and the mechanism may involve high energy trauma, like where it could be from penetrating from outside, and there is a very unstable fracture with the different degrees of fragmentation. Then in again there is a subcategory 2A that wound have sufficient healthy soft tissues cover the bone without the need for the flap coverage or the bone projection. We will come across again this importance when later on when we read to Sushruta in the last part of our chapter. Sushruta mentions about a rule of management of the compound fracture. Sarvanasya bhagnasya, sarvana bhagna, nirgatam astin nirahpayat. You have to remove that projected bone as one of the management of the, we'll come to that part when we go further into the text as such. Now, in case of that second A, there is a projection of the bone, but that projection of the bone doesn't need to be handled or doesn't need to be removed, and it can be covered by the soft tissue. Third B is a disruption of the soft tissue where there is extensive distant flap coverage, and hence the bone cannot be covered easily. So either to cover the bone you may have to have a graft of the tissue, or at times you may have to remove the bone and use a bone graft. And third C is a open fracture with the associated arterial or neurological injury, which requires a multidisciplinary approach. And that's the issue. Now, the same time duration and those factors are considered by Sushruta when he discussed about the prognosis. Now, from the general our current point of view, as I told, the golden rule of orthopedics says that the no fracture would unite before 3 weeks. Sushruta says like प्रथमे वैशिष्ट्यं मासात् सन्धिः स्थिरो भवेत् मध्यमे द्विगुणात् कालात् उत्तरे त्रिगुणात् स्मृतः. In the younger age, the fracture unites by about a month. So least period for the union of fracture according to Sushruta is 1 month, whereas in the current this trend or contemporary guideline is 3 weeks. Now the factors which can change this would be the enhancement, the duration of the healing could be longer in the later age period. In old age, it could be thrice 3 months required. In the younger age, it could be 2 months. Of course, in the current situation, we have the modification of the rules the other way, like 3 weeks is the least period in any condition, and if it is a lower limb fracture, it's the 6 weeks. And of course, in older age, in a patient with above 60, the least period is considered as 6 weeks. That's the current guideline would say. Now, Sushruta has said, Pratame Vaisitvayam Bhagnam Sukarmadishet Alpudavashasya Jantostu Kalecha Shishiratmake. The management of a fracture is considered to be having a better prognosis or easy in Prathama Vayas or in the younger age. This again is point which you have referred to in case of the Nidana, Bhagna Nidana. Sushruta has said the younger age is, the prognosis is poor. Young and old age, both conditions, the prognosis is poor according to which is mentioned in the Nidana Sthana. Of course, the point is it's not a controversy. That's a point which you have already discussed in the Nidana. Again, it's a repetition of the same. It's not a controversy. It's about the whole facilitation of the management. Younger children would not have a cooperation, and to immobilize them would be quite difficult. And hence, in one context, he has considered this as having a more troubled course, and hence it's considered as kasta subject, krita subject. Whereas, as far as the healing period is lesser, as healing is faster in younger age, because you have more fresh tissues, that is considered as a better to treat as such. Even now, with all that physiological aspects, we know that the life cycle of the bone and the metabolic activity is better in a younger age. In the younger age of the whole life cycle of the bone and the activity of the bone is actually rapid and high. It is going on enhancing up to the age of 20 or 22 years. Then it becomes stabilized, and by the age of 50 or plus, then gradually it gets diminished. And hence, there is always a risk of osteoporosis naturally occurring, unless there is some, if there is some other triggering factors related to the health and lifestyle, this process may become faster. That modification of lifestyle may slow down the process, but this osteoporotic changes after the age of 50 is a natural age-related phenomena. And whatever Sushruta has mentioned, as far as the course of the union of the bone, it's practically proved with the physiological aspect of the bone growth and bone metabolism. Then the principles of the management would be अवनान्वितम् उन्नश्येत उन्नतं च अवपीडयेत आञ्छेत् अतिक्षिप्तम् अधोगतं च उपरिवर्तयेत आञ्छनैः पीडनैश्चैव संक्षेपैः बन्धनैस्तदा सन्धीन् शरीरे सर्वांश्च चलानपि अचलानपि एतैस्तु स्थापनोपायैः स्थापयेत् मतिपान्भिषक्. The whole principle of the management of a fracture is the first is the reduction. As we have discussed about the reduction is simply attempting to re-establish the previous normal anatomical entity or reducing the deformity produced by the fracture. Once there is a fracture, there is always a possibility of the displacement of the fracture, And of course, a point which we have discussed during the Nidhanasthana, the different sorts of the displacements, and based upon that, Sushruta had categorized 14 types of the bhagna, bhagna vishesha. Now, based upon that, studying that defect would be one of the important issue, and then you have to reverse the process. And from the current definition, we usually define that reduction as the reversal of the injury. So to know exactly, you should know how the injury has occurred. So history taking of the fracture is one of the important issue. And how far the displacement would occur also will be depending upon the momentum of the injury, as well as the body weight which can act upon the area. Any other factors which have mobilized further, like a patient of a fracture, when he is brought to the hospital, there could be some displacement again, and how the patient is handled, that's also one of the factors. So all these factors would be considered before you assess the deformity, as well as the imaging studies now can give you a better idea about the deformity, and only after studying the exact deformity, the deformity can be corrected. And the principle of the correction of the deformity is, if the deformity has produced depression, that depressed area has to be elevated. If the area is elevated, the elevated portion has to be depressed. If there is a proximal displacement and shortening, that has to be pulled apart. Unchecked is the traction, a traction has to be given. Then atikshikta, if there is a overlap, the bones are distally displaced, like the gap is enhanced, then they have to be brought together. And these are summarized by Sushruta as Anchanehi, Piranehi, Chaiva Sankshepaihi, Bandhanestada. Anchana is the traction, Pirana is the local manipulation, by which the local manipulation of either depressing or elevating, so on. Then Sankshepana is reducing the space, like proximal displacement. And then the bandhana, the immobilization is done. And this is the basic principle of the management of fracture. Even now, with all the advanced technology, and whether you do it by the open reduction techniques or by the closed reduction technique, the whatever you do is the same. In the present day situation again, the goals of the treatment are considered as one is to prevent the infection and to allow the fracture to heal. That allow the fracture to heal is done by the same reduction, immobilization aspect. Then the next there is another part which we now consider as the goal of the treatment is restore the functions in the injured limb by rehabilitation. So the summary of the treatment aspects are considered reduction, immobilization, and then the rehabilitation. The patient has to have the function. And the whole principles of the management are, the first of course, once the patient of fracture is brought to you, you take care of the vital forces which can. Hello. 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 ಹೌದಾ ಸರಿ, ಇಂಟರ್ನೆಟ್ ಅಂತ ಇಲ್ಲಿ ಜೋರು ಮಳೆ ಉಂಟು. ಸರಿ, ಟ್ರೈ ಮಾಡ್ತೇನೆ. ನಾನು ಬೇರೆ ಮೊಬೈಲ್ ಇದು ಇಂಟರ್ನೆಟ್ ಹೋಗಿಲ್ಲ. ಸರಿ, ಟ್ರೈ ಮಾಡ್ತೇನೆ ನಾನು. ನಮ್ದು ಇಲ್ಲಿ ಮೊಬೈಲ್ನಲ್ಲಿ ಇಂಟರ್ನೆಟ್ ಸಿಗ್ತಾ ಇಲ್ಲ, ಮಳೆ ಸಿಕ್ಕಾಬಿಟ್ಟಿದೆ. ಸರಿ, ಇವತ್ತು ಹಾಗೆ ಕ್ಲಾಸ್ ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿಬಿಟ್ಟೆ, ಆಗುದಿಲ್ಲ. ನನ್ನ ಮೊಬೈಲ್ ಡಾಟಾದಲ್ಲೂ ಕನೆಕ್ಟ್ ಆಗ್ತಾ ಇಲ್ಲ, ಇಂಟರ್ನೆಟ್ ಇಲ್ಲ.